Thanks so much for having me. I'm Richard Dillon from King's College London, and I'm going to speak about molecular diagnostics in AML with a special reference to minimal residual disease assays. And I'm going to talk about how these can be used to personalise therapy and hopefully to improve outcomes for patients with this devastating malignancy. I think it's worth saying right at the beginning that it's absolutely essential as these tests are used more and more to influence management that the results are robust and comparable between labs. And it's important to point out that UK NEQAS already have a range of molecular EQA programs set up with, I understand, more to follow. So the journey towards personalised MRD-guided management in AML is one that's still very much ongoing, and it's one that I'll consider in 3 steps. So the first step is to use MRD data and other molecular data to refine risk stratification in order to give patients an indication of their likely outcome. And on this point, there are now a very large number of large, robust studies across different countries and trial protocols. Moving on from that, the next stage is to then use this prognostic information to design risk-adapted protocols. And although there are not significant amounts of published randomized data to support this point, it's something that's very much been adopted by almost all large AML trials around the world. And specifically within the UK, all 3 current UK AML trials are using a risk-stratified approach. And the rationale for that is as follows. So in AML, as I'm sure you know, the main cause of death is disease relapse. But this is closely followed by treatment-related deaths from bone marrow transplantation or intensive chemotherapy. The idea of risk-stratified treatment is that those patients that have a relatively low risk of relapse can have their therapy de-escalated, sparing some of the toxic deaths, whereas those patients who are predicted to be at a very high risk of relapse can have their therapy intensified, hopefully reducing the risk of relapse. And then finally, I want to speak about the kind of cutting-edge use of these technologies, where we try and move away from putting patients into small numbers of risk groups and accurately identify the risk of relapse for each individual patient and use that to personally tailor therapy so that each patient receives precisely the amount of treatment they need to cure their disease and no more. So to start with, I'm just going to review the evidence base for using molecular MRD tests to refine prognosis in AML. And as I'm sure all of you know, the backbone of risk stratification for this disease for many years has been based on the cytogenetics at presentation. And what you can see from this graph is that this provides extremely powerful prognostic information, dividing patients into groups with extremely different prognosis. However, there is a small shortcoming for that, which is, I think, highlighted if you look at the red and the green lines here, which is patients with poor binding factor AML who have a favourable prognosis. But nevertheless, if you see with long-term follow-up, a very significant number of these patients will relapse and die from their disease. And it would be extremely useful to be able to pick these out earlier on in their disease course so they could have their therapy prospectively intensified. And the problem is even greater in the case of patients with a normal karyotype, who have approximately 50% chance of long-term survival and 50% chance of relapse and treatment and death from their disease. So the role of molecular MRD techniques is very much to pick out patients in any of the risk groups who are predicted to do better or worse than average. But, before moving on to that, I think it's worth, you will hear about next generation sequencing panels from the next speaker, and this is something that's become very popular in the AML field recently. But there is an important shortcoming to these kind of techniques, which I think is often overlooked. And the point about this slide is that you can't consider the prognostic significance of mutations on their own. The actual prognostic effect is clearly dependent on the mutational context. And to explain what I mean, this is a slide from the recent Sanger paper from a large German cohort of over 1,500 patients. And this is just looking at the 3 most commonly mutated genes, FLT3, NPM1 and DNMT3A. And what you can see from this figure is that FLT3 ITD, commonly held to be an adverse prognostic factor, actually only really has relevance in the context of a co-occurring NPM1 and DNMT3A mutation. And in all of the other mutational contexts, it loses prognostic significance. So that means that we cannot simply look at mutations in isolation. We have to consider the combined genotype of each patient. And an example, and just to show you how complex this becomes, this slide shows data from the AML-17 study. And this is just looking at patients with NPM1 mutated AML, which is found in approximately 1/3 of adults. We had 223 such patients in AML-17, and we performed targeted sequencing on these patients. And we were able to divide these patients into 161 separate subgroups. Even when we looked at the 17 most commonly mutated genes, we were able to define 89 separate subgroups, which are shown here, many of which are very small indeed, and this makes any kind of a statistical analysis extremely challenging without many thousands or tens of thousands of patients. And this is data that we simply don't have at the present time. In contrast to this, when we look at these very same patients, but we look at the presence or absence of NPM1 mutated transcripts by RT-qPCR in the peripheral blood after 2 courses of chemotherapy, you can see that this simple blood test actually divides patients into groups with a vastly different prognosis regardless of their genotype. So the line in red here shows patients who had detectable NPM1 mutant transcripts in the blood after 2 courses of chemotherapy, and you can see that they have an 83% chance of relapse and just 25% chance of long-term survival, in contrast to those who had undetectable transcripts at this time point, who had a 77% chance of overall survival. And when we performed a multivariate analysis on these patients, the MRD status actually outweighs all the traditional clinical risk factors such as age and white blood cell count, but also the mutational status of a 51 gene panel, including the 3 genes which I mentioned on the previous slide. And this has not just been shown by the UK trials, but this has also been replicated by other groups across Europe. So this slide shows data from the French Alpha 0702 study, and what you can see from this is they looked at the PCR status in the peripheral blood post-induction. Those patients who achieved a 4-log reduction or greater in the peripheral blood at this time point had just a 21% chance of relapse with a 92% chance of overall survival, compared with those patients who did not achieve a 4-log reduction who had only a 41% chance of overall survival. And then similarly, this was replicated by the German AML-SG 0704 study. This paper was published in 2001 and shows that those patients who have a complete molecular remission in the bone marrow after the first 2 courses of chemotherapy have only a 6% chance of relapse and a 90% chance of overall survival. And this data was then updated at the last ASH meeting with a larger number of patients with a longer follow-up, and similar results were seen. And the other important point from this study is that although the early time points are clearly very important, looking at the PCR status in the bone marrow at the end of therapy is also critically important, with those patients who still have transcripts detectable in their bone marrow at the end of treatment having an extremely high risk of relapse. So all the data I've shown so far relate to patients with NPM1 mutant AML, but such techniques can also be applied to patients with any kind of gene-gene fusion, which is present in a further approximately 20 to 30% of patients. So these data are from AML-15 relating to patients with core binding factor AML. And what you can see is this is the PCR status after just 1 course of chemotherapy, and we can already pick out a number of patients who have an extremely high risk of relapse with T821. And similarly, for inversion 16, we can define a group of patients who has an extremely high risk of relapse, as well as an intermediate and a favourable group. And again, these findings have been replicated across European studies, and this is a figure from the Alpha CBF 2006 study, and this is looking at patients after 2 courses of chemotherapy. Those patients on the black line here achieved a 3 log reduction in fusion transcript expression, whereas those patients in the dotted line did not achieve a 3 log reduction, had a markedly higher incidence of relapse. And finally, although the data I've shown you so far are focused on RT-qPCR measurements, there are a number of publications in the last 2 years looking at the use of next-generation sequencing for MRD analysis. And this is something that is probably almost ready for clinical application. This paper was published in the New England Journal of Medicine very recently, and this is from the Hovon-Sack group. And they looked at whether they could detect any of the mutations seen at diagnosis in follow-up bone marrow samples. And when they excluded mutations that were associated with non-malignant clonal hematopoiesis, or CHIP, so these are mutations in DNMT3A, TET2, and ASXL1, when they subtracted these mutations from the analysis, any other mutation remaining after treatment was associated with a markedly higher risk of relapse. And importantly, the information provided by next-generation sequencing was an additional to information provided by flow MRD-based techniques. So what you can see here is those patients who are positive by flow and NGS had a very high chance of relapse, whereas those patients who were negative by both techniques had actually a very favourable outcome. So I think this demonstrates quite conclusively that MRD status is a very powerful prognostic factor, and this applies regardless of the molecular target of the platform used. And now what I'd like to talk about is how this can be used to build risk-stratified treatment algorithms. And as I mentioned on this point, there are few published data, but I think that this study from China is very interesting. So this is looking at patients with T821, and they enrolled 137 patients. And the patients had 2 courses of induction and then 2 courses of consolidation chemotherapy. So these patients achieved what they call a major molecular response, which means that they had a 3 log reduction in RON21 fusion transcripts, and they were recommended to undergo further courses of consolidation chemotherapy. Those patients who didn't achieve a 3 log reduction were recommended to undergo allogeneic stem cell transplantation. But however, not all of the patients did what their doctors advised them to do, so there was a group of patients with a favourable response who went for transplant, and there was a group of patients with an unfavourable response who declined transplantation and elected to undergo further chemotherapy. So this is not a randomised study, it's clearly prone to potential biases in a number of ways. But however, the results of this are very interesting. So if we look at the top plot here, this is patients who had a favourable MRD response. And those patients on the black line at the top followed the MRD-guided consolidation chemotherapy approach, whereas those patients on this line demanded to undergo transplantation in spite of their favourable response. And you can see that they had a worse outcome, and this was statistically significant, so this is likely to represent transplant-related mortality. And similarly, if you look at patients in the bottom panel here who had an unfavourable molecular response, those patients who underwent transplant as advised actually had a reasonable long-term outcome, whereas those patients who declined transplant did very badly indeed, and again this was highly statistically significant. And similar example of using this kind of data to allocate therapy was provided by the French study. So this graph, it looks very complicated, but really what you can see on the blue and the yellow lines is these are patients who had a favourable MRD response, so they had negative or greater than 4 log reduction in NPM1 mutant transcripts post-induction. And the ones in the blue line had consolidation with chemotherapy. And the ones in the yellow line had transplantation. And you can see that the ones who were transplanted with their favourable MRD response seemed to do significantly worse with the patients who had chemotherapy, although this was not statistically significant due to small numbers. So in contrast, the patients in the grey and the red lines are patients who had an unfavourable MRD response with a less than 4-log reduction in NPM1 mutant transcript levels. And you can see that those patients who underwent transplant do much, much better than those patients who were consolidated with chemotherapy alone, and this was statistically significant. So these findings really support the approach that we're using in the UK and actually many countries around the world of using MRD status at certain checkpoints throughout treatment to allocate patients to more or less intensive treatment blocks. And just to give you a couple of ideas, I'd just like to show you the current outline protocols for the AML trials that we're using in the UK at the moment. So this is the AML-19 study, this is the current AML-19 study from the last update. Patients who have NPM1 mutation are divided into 2 risk groups on the basis of their post-course 2 MRD status. Those who are negative receive consolidation chemotherapy. Those who are positive are randomized between 2 salvage therapies and are then allografted. Similarly, those patients who are wild type for NPM1 are followed by flow cytometry in Sylvie Freeman's lab in Birmingham. And those patients who are flow MRD negative after course 2 again receive standard consolidation chemotherapy, whereas those patients who are positive by a flow MRD again go into the high-risk arm, are randomized between CPX and FLAG-IDA and transplanted. Similarly, this is the AML-18 study for older adults, and in this group only a small number of patients have molecular MRD targets. So these patients are all assessed by flow MRD with a late assessment at diagnosis and then an MRD assessment of a post-course 1 time point. And based on these results, patients are either directed down this arm, which is for patients who are MRD negative, or the bottom arm here for patients who are MRD positive, which involves intensifying therapy and addition of a small molecule, and ultimately referred for transplant if the patient's suitable. And finally, this is the protocol for the current paediatric study, My Child 01, which is now running in the UK, France, Ireland, and soon Australia. And this looks horrendously complicated, but essentially it involves MRD assessments by both molecular and flow-based techniques at various time points throughout treatment. So patients are initially assigned to an upfront risk group according to their cytogenetics, but after course 2, all patients have an MRD assessment. Those patients who were good risk by cytogenetics, but they remain MRD positive, are now pushed down into this intermediate risk treatment arm, which means that they have their therapy intensified. If they still remain MRD positive after the 3rd course of chemotherapy, even if they have good risk cytogenetics, they then go into a high-risk arm and get transplanted. Similarly, if a patient has intermediate risk cytogenetics, but they go MRD negative after post-course 2 by molecular and flow, they can have their therapy de-intensified and they go down this standard risk treatment arm. So in the final part of my talk, I just want to speak about how we can use MRD techniques to further personalised treatment for patients beyond putting them into these broadly defined treatment groups, and how we can begin to enter the era of personalised medicine. So just to review what happens to patients who have detectable disease-related transcripts after completion of treatment or during follow-up, and I think that's very clear from multiple studies. So this is patients who have detectable NPM1 transcripts above a certain threshold during follow-up. And what happens to these patients is that they all relapse, and they all relapse, the median time to relapse is around 3 months. And then this is looking at patients with T821 AML who have RUNX1, RUNX1T1 transcripts above a certain defined threshold in the peripheral blood or bone marrow. And what happens to these patients is they all relapse, and they all relapse within approximately 4 to 6 months. And finally, this is looking at patients with inversion 16 AML who have disease-related transcripts above defined thresholds in the peripheral blood or bone marrow during follow-up. And what happens to these patients is that they all relapse again within a few months. The time to relapse, as you can see from those preceding slides, it can be very variable between patients. And this is critically dependent on the molecular subtype of disease. So what you can see from this slide is that patients with inversion 16 AML tend to relapse more slowly than average. And the time from molecular relapse to frank relapse can be as much as 6 months in some cases, giving further time to intervene. Whereas those patients with MLL translocations, the time from molecular positivity to frank relapse could be as short as 1 month. So this means that the strategy in order to treat this molecular positivity has to be determined by the particular molecular subtype of disease. So what I'd like to do is just review the kind of treatment options that could be considered for patients who have molecular relapse to preemptively treat and prevent them from having a frank relapse, which could potentially be associated with severe complications or reinduction death. So a number of different treatments have been tried in this setting, and the first one is to try small molecules. So this is a trial which was performed for dasatinib for patients with core binding factor AML, many of whom have mutations in c-KIT. And this was looking at patients who had molecular persistence or recurrence of disease at the end of treatment. And what you can see from this is that the treatment with dasatinib in this situation appears to make no difference, although the numbers are small. The second option to consider is a low-intensity treatment with hypomethylating agents such as azacitidine. This is a small phase 1-2 study from Germany, looking at patients who had a molecular relapse after transplant. These patients were treated with azacitidine, which is shown here in the green lines. And what you can see is that of the 20 patients treated, 4 patients had a complete response to treatment, and these responses were maintained long-term. Additionally, a further 6 patients had a transient response to azacitidine. The remaining patients had either a minor or no response. However, importantly, although 13 of these 20 patients ultimately relapsed, the median time to relapse in these patients is 231 days, which is markedly shorter than the historical median of 61 days. So it appears that use of azacitidine can prevent relapse in a small proportion of patients, but more importantly, delay relapse by quite a long time in many others. And then this was further explored in the RELASER-2 study, which is a much larger study, which was reported at the last ASH meeting. In this study, they enrolled 205 patients, of whom 58 had been transplanted. And during follow-up, they recorded molecular relapse in 53 patients. And these patients were then treated with azacitidine for 6 months. At the end of month 6, 58% of patients were still in morphological complete remission, whereas 42% of them had relapsed. And there were 8 subsequent relapses, but overall the time to relapse was 482 days, again very significantly longer than previously experienced. Of interest, those patients who were transplanted appear to have a much higher overall response rate than those patients who had not received a transplant, suggesting that azacitidine may have an effect by influencing the donor immune system. Final treatment option to consider for patients with molecular relapse is donor lymphocyte infusion. So this is just to remind you that the outcome of patients with frank relapse post-transplant who were treated with donor lymphocyte infusion is not good at all. So the yellow line is patients who did not receive DLI, and the blue line is patients who received DLI for frank relapse. And what you can see is that the long-term survival is less than 20%. So can we do better by treating patients at molecular relapse before they come to frank relapse? And the answer is probably yes. So this is a small study which was published by an Italian group a few years ago, looking at patients who were MRD positive using the WT1Q PCR assay. So this is an assay which is not particularly leukemia specific or sensitive and has largely fallen out of routine use. But however, what you can see for those patients who received donor lymphocyte infusion at MRD positivity, they had a significantly longer overall survival than those patients who did not receive DLI. And this slide shows data from the AML 17 study, looking at patients who had a molecular relapse after transplant. And what you can see in the blue line is the patients who were treated with donor lymphocyte infusion at the time of confirmed molecular relapse. And they have a very impressive, almost 80% 4-year survival. And this compares quite in marked contrast to those patients who did not receive DLI. Only 13%, 4 of them were alive. But importantly, 2 of these patients actually had gone for second transplant. So I'd just like to finish by showing how these techniques can be used in real life. And I've just got 2 kind of patient histories to show you. So this first patient is a 72-year-old man. He's very, very fit and healthy, but he was not a transplant candidate due to the fact that he had a renal impairment. This patient was treated with standard induction chemotherapy, and you can see that he had an initially good response with about a 3 log reduction in transcript levels, and then a further log reduction with cycle 2. He then went on to have consolidation with high-dose cytotherapy, and what you can see that his response then starts to plateau. Following this, we intensified therapy for cycle 3. However, there was no response to this. Actually, transcript levels had risen. We did wonder if this was a mistake. This was repeated and confirmed. We then tried again to refer the patient to the transplant centre. This again declined. We then applied for Mylotarg, gemtuzumab, ozormycin on compassionate use basis, and start to see a decline in the transcript levels, which was transiently dropped by a further 2 logs, and then again the response seems to be lost. And we then applied for use of venetoclax, again on a compassionate use basis, and the patient has now been on venetoclax azacitidine maintenance for approximately 1 year, and remains in a molecular complete remission. The second patient was a transplant candidate. It's a 22-year-old male, but in contrast to the other patient, this one had significant comorbidities. He had a morbid obesity. The transplant consultants reckoned that he had up to 50% chance of transplant-related mortality. So in this case, the patient was not sent for transplant in first complete remission. But what you can see from this is that the patient had induction chemotherapy and actually had a very good response initially. But again, after the second cycle of chemotherapy, the response seems to plateau, and there's no further response to high-dose cytotherapy and consolidation. So the clinicians were aware that this patient is now definitely going to relapse. But despite this, because of the risk of transplant, they wanted to see that the transcript levels were rising before they went forward and committed the patient to transplant, because there was such a huge risk of complication. So we monitored this patient for about 6 months, and what you can see is, at about this point, the transcript levels start to rise rapidly, and this was then confirmed on the second sample. And this patient is now probably just 1 log from frank relapse. The patient then received salvage therapy with FLAG-IDA, remains MRD positive pre-transplant, and actually on their day 30 marrow, they were still clearly MRD positive, which was repeated, and the transcript levels will start to rise. So without further intervention, we know that this patient is going to relapse. We know that relapse post-transplant is associated with an absolutely dismal chance of survival. So the patient went on to receive donor lymphocyte infusion. This resulted in a rapid drop of transcript levels, which then became completely negative, and the patient remains negative actually as of last week. So to summarise, I've presented data to show you that MRD status provides very powerful prognostic information for patients with AML, and this is consistent across a range of techniques, including qPCR, next-generation sequencing, and flow cytometry, meaning that MRD assessment can now be offered to all patients, and that in fact many patients could benefit from more than one technique. Second, I've shown that MRD-based risk stratification, which is now applied across all the current UK clinical trials, can be used to better balance toxicity of treatment with therapeutic effect. And finally, I've tried to show how serial monitoring can be used to personalise patients' treatment, both to prevent relapse and to gain the maximum benefits from novel therapeutic agents, which are becoming increasingly available. I'd just like to finish by thanking all our lab team and also members of the UK NCRI Paediatric and Adult AML working groups. Thank you very much. I'm happy to take questions.